And good morning, everyone. Welcome to I heard myself. PerfWeb 77,
Amateur.
Day 1. Amateur. Yeah, I know. Thanks. PerfWeb 71, Day 1, Tammy Sparacino Journal Club. Welcome, Tammy. Good morning.
You.
It's good to see
I
you.
think we're PerfWeb 77.
Isn't that what I said?
I don't know.
PerfWeb 77,
Okay.
Day 1,
Okay.
in case I got it wrong. Okay, so very quickly, we're going to go through our usual routine, abridged version of it, though, if you don't mind. So a couple of things. One, you can reach out to us at contact@perfusioneducation.com and send us an email if you'd like to contact us. Of course, going to PerfWeb, joining the perfusioneducation.com website, which is a free membership, but you can earn by all of your CEUs for your ABCP certification that you may need for those of you who have travel restrictions, those who may be out of the country. Of course, thank God COVID is finally starting to abate. I think in a big way. At least it seems that way to me. But I'm hesitant, Tammy. I don't know where you are with all of this, but I'm hesitant, like, to be overly excited that it seems like...
Don't be too optimistic.
But I have to be. I have to be. Because I don't know how our audience feels, but I can't go through that again.
Well,
I don't know how you feel, but I can't.
We're entering year 3.
But do we really have it? We don't really have it. Like, we don't have it. We're not seeing it.
Well, whether or not we see it doesn't mean it's over. I mean, they're still calling it a pandemic, entering year 3.
Yes.
So it's affecting some people, just maybe not us.
Yeah. I'm talking about the level we were for the past 2 years. I mean, I just don't, for the preceding 2 years. And in all seriousness, I just don't believe that I could go through that again.
No.
I just don't.
I certainly don't want to.
We already got a comment.
Oh, yeah.
Hello, my friends. I want to ask you about the difference between the oxygenation and CO2 removal in the oxygenator, and is the oxygen line cylinder enough to do the job of both of them? Well, absolutely. Ala, it's nice to see you. Tell us where you're from, if you don't mind. And I'm not sure if that's your first name, last name, middle name, but maybe let us know who you are and where you're from. So, yeah, I think traditional oxygenator will work very, very effectively for oxygen transfer and CO2 transfer. That's what they're designed for. I think that when you start seeing the fibers starting to become a little coated, and maybe some of the pores being occluded, you generally start to see a degradation in CO2 transfer before you see the drop off in O2 transfer, as a general rule.
Yeah.
That's usually what I see anyway, clinically. But as far as with the oxygen line cylinder, whether you're hooked up to a tank, which don't run out, then it doesn't work at all, or make sure that you're hooked up to wall, as long as you are using either 100% O2 with plenty of flow. And as you know, usually when we do VA ECMO, you're never going to do anything but 100% FiO2 on your gas inlet. You would never wean your FiO2 on a VA ECMO because you're not going to want to pump anything but high oxygen into your...
In case you need to clarify, tell them why. Because it's not passing through the lungs, right?
Right.
So there's no opportunity for additional oxygen to be added before
Right.
it's delivered to the body.
Right. You don't want to pump desaturated blood into the arterial tree.
Versus being a VV, then
Right.
of course it's passing through the lungs depending on what the
Right.
lungs are doing.
Right. Your weaning protocols for VA and VV are vastly different. For VV, because it's a closed loop system, you will usually keep your flows up, decrease your FiO2 in your sweep, and for VA, you would cut your flow down. Now, the advantage, disadvantage, obviously, is on VA, you have to respect the lower flow, longer transit time through your system, more opportunity for clots to form, so your anticoagulation has to be a little higher. In VV, you have the opportunity to keep your flow higher and less need for, because if you have your gas line off and you're just going around in a circle and providing nothing except a closed loop recirculation into the right atrium, it doesn't affect anything unless the cannula is malpositioned and affecting your cardiac output in some way. Then, and I think that's part of your talk today and something to take into consideration. Is there anything, I hope that answered your question, Allah. David, is there anything I forgot? Like, am I supposed to talk about anything else?
Just the call-in number.
The call-in number, which is up on the screen right now. Of course, please go to check out our podcasts on your favorite streaming podcast service. You can find us on PerfWeb. Just look that up, or Perfusion Education, and you'll find our podcast there. Can listen in the car to some of our discussions, which I think are very robust and meaningful. Sometimes they're silly, but, you know, for the most part, there's a good message in there somewhere. And then also check out our app. Go to the Google Play or the Apple App Store, and you can look up the MediWeb Clinical Perfusion and Critical Care app, or Critical Care and Perfusion app, however it's couched. And it's only $2.99. It's really worth its weight in gold. We should have really made it for $29, not $2.99, to be frank with you. I mean, listen, it was a very expensive app to create. These are not, it is not, making apps is not as simple as it seems. You can make a pretty rudimentary one, but this is a very complex app, I think. Do you use it at all? Have you ever used it? Do you use it?
Yeah.
I like it. I use it. When I go down to Southeast, I use it down there.
Yeah.
And can I make another announcement too? I can make an announcement, and it has to do with the American Board of Cardiovascular Perfusion. I wanted for those of you who may not know, I wanted to congratulate Ann Greco on her appointment as the president of the ABCP.
Yeah.
So, Ann,
congratulations.
For those of you who may know Ann that might be watching right now, please send her a congratulatory note. I think she would greatly appreciate that.
Absolutely.
So I think I am, okay, so thank you very much. I am Abdulrahman Al-Humiani. I don't know if I said that right, but you're a cardiac perfusionist from Saudi Arabia. Well, welcome.
Thanks for watching.
Yes, absolutely. And thanks for participating. Actually, we're going to need your address because we're going to spin the wheel a little bit later on. Okay. And I think I've belabored enough. I apologize for all of the preliminary discussions and stuff, but they were good. We're going to talk today. Tammy is going to do a journal club, the Tammy Sparacino Journal Club, on safely repositioning the dual Lumen ECMO cannula with a transfemoral Lasso snare. Now, I'll tell you, even though this is more perhaps written for the pediatric world, it translates into the adult space very, I think, nicely. I've had my own horrifying experiences now twice with having to replace an Avalon catheter that had malpositioned and couldn't get put safely back into the inferior vena cava without disconnecting it, putting the
wire,
not the guide wire, but the dilator, you know what I'm talking about, what am I trying to say? Well, the piece that goes inside, and then putting
the introducer.
The introducer, thanks.
Yeah.
And then putting the wire back through and feeding it in. It was bloody.
Which means you have to come off ECMO.
Yes, it was bloody. It was destabilizing. That was later abandoned for just putting the introducer in, throwing a wire in quickly, pulling it all the way out, and then not trying to reposition that same catheter and changing the catheter out. We tried several different things, but we didn't do the patients survived. All of the patients that we did 2, survived it, but I was thinking there has to be a better way. And we came across this article, and I thought it was very, very timely. And it was a brilliant idea. My only disappointment is that I didn't think of it, because it seems so such an incredibly smart thing to do. So with that said, Tammy Sparacino, Journal Club, it's all on you.
Okay. Thanks, David. We bring up the slides. All right. Thanks, everyone, for joining us. So Joe let you know that we are going to be talking about repositioning a dual lumen ECMO cannula with a transfemoral Lasso snare. Now, this article was published in the Journal of Perfusion, and it's actually out of Houston, here in our Texas Medical Center, Baylor College of Medicine, and Texas Children's Hospital. The physicians there and the Department of Pediatrics wrote this article by Erica O'Neill and her colleagues, and we're going to just look at 3 patients that they were able to use this technique to reposition. This was published in 2020. All right, let's get into the abstract.
And Perfusion is your favorite journal, isn't it?
Yes.
You love that journal.
I do love that journal.
I like it too. It's really good.
They've got a lot of variety for the articles that they put in there. So, I think it's pretty interesting.
I think so.
Okay, let's get into this. So, brief introduction. Dual lumen cannulas were provided to provide veno-venous extracorporeal membrane oxygenation, VV-ECMO, with single vessel access. Anatomic and size considerations may make appropriate placement challenging in children. Dual lumen cannulas are repositioned in 20 to 69% of pediatric patients.
I'm sorry to interrupt you.
Yeah.
Do you find that to be similar to in the adult world?
I don't think that's much different in the adult world. I think that just depending on how long your ECMO run is, you're going to have to readjust your dual lumen cannula.
Agreed.
Yeah. Which can be difficult without transient discontinuation of ECMO support. So in this particular article, they discussed repositioning 3 dual lumen ECMO cannulas introduced via the right internal jugular vein using a transfemoral snare technique under real-time ultrasound and fluoroscopy. The results: 2 of the 3 patients were supported on VV ECMO and 1 on veno arterial ECMO. 2 of the 3 patients had their dual lumen cannulas repositioned under ultrasound and fluoroscopy guidance, and 1 was just repositioned with ultrasound. No patient experienced a complication from the transfemoral snare technique, such as femoral hematoma, hemorrhage, or limb ischemia. Conclusion: they described 3 patients who successfully had their cannulas repositioned without cessation of ECMO. All right. So,
quick question.
Yeah.
Do you have any good images, any X-rays of malpositioned in your talk today?
I have the ones that they provided.
The ones they provided?
Yes.
That's good. That's good. Because
Yeah,
I have a few too for the adult space, but we may not need them.
Okay, well, we'll talk about these and we can go from there. So obviously the reason why this is published, many times when you are having to readjust these cannulas, the patients are too unstable to really withstand coming off ECMO even for a brief period of time. So having some sort of technique where you're able to do these adjustments, because the migration of the cannulas are pretty common. You having to adjust the patient. You might have to move the patient from their ICU room to take them somewhere. All of those sorts of things, or the cannula not being sutured in tight enough, the patient having volume status changes, all of those things can affect how well your cannula is positioned. So obviously this is a problem that doesn't go away. So if we have a solution that we can do this without coming off ECMO, that would be good. Okay, so the problem to be solved is, of course, will this work? And we're going to see that indeed this technique was very effective in these 3 patients, and they were successfully able to do that. Okay, their materials and methods. So they used a multi-snare 10 to 15 millimeter retrieval loop, inserted it into a 4 to 6 French sheath into the femoral vein. Real-time ultrasound and/or fluoroscopy image guidance. The Avalon tip is then snared in the loop. The surgeon is working to advance the cannula from the neck. The cannula snare guides the repositioning. The tip is repositioned into the intrahepatic IVC. The return port jet is towards the tricuspid valve. Monitoring venous filling pressure, oxygen saturations, and ECMO flows all during this. The heparin anticoagulation infusion rate was not modified during the procedure. They didn't give more. They didn't temporarily stop it. They kept it just exactly where it was.
So do you know where the, and if I'm interrupting you at the wrong time, just tell me, don't interrupt me. I wasn't sure. So you know where the first time that, and why I'm so mad that I didn't think about this before myself?
Why?
Well, when I first started doing angiovac procedures. We were using...
What was that? How many years ago was that? Wasn't that long ago. 5 years? 6 years?
Six, yeah, maybe 6+.
Yeah, because I think the first time I saw the angiovac system was at one of the New Orleans conferences.
Yes. That was probably 6 years ago at least.
Yeah.
I don't think... it was a while ago.
It's been a little while.
I don't want to say it because, that means we're all getting older. But we used to go... and then it was being used to debulk, declot the IBC filter. And then they would use snares to go
catch it.
up. No, they would suck off the clot and stuff, but then they would use snares inferiorly and superiorly to grab a hold of the IBC filter, and when they pulled, it would collapse it, and then they could pull it out.
Oh, I thought you were going to say they snared clots.
No, so when I'm thinking how I saw them using the snare.
You should have had this idea already.
Yes, I'm just mad I didn't because it's such a brilliant idea.
Yeah, it is really. Okay, so here's the images that were provided in this article.
You want to highlight or anything? You just tap it. Tap the screen.
Okay.
Yep, that's it right there. And then you'll have your laser.
Okay. All right. So this is figure 1, and these are the images of patient A, which we'll get into the specific patient shortly. But this is a 2-month-old male on VV ECMO. And you can see the tip of the Avalon cannula is high in the right atrium. And let's see. It's kind of hard to see on the first image, actually, but let's see.
No, I can clearly see it. I can see it way up there.
I can't see where it is, actually.
Here,
so
where's your little marker?
It's there.
It's right here.
Yeah, okay, that's what I was going to say. Yeah, right there. That's it right there, right? Yep. Okay, so
and
here we go.
It needs to be way down. It's way too high.
Yeah, this is where the tip is. Okay, so then on image 2, you can see that the transfemoral guided snare is looped around the cannula. So come up here and you see the arrow, and there's the cannula, and they've looped it there. And then it's pulled down, and so they're taking it here, pulling it down here until it rests right here. There you go. You can see it. That image is pretty clear to me. I can see it pretty well.
Yes.
And
yeah, you don't even see it in the left image.
Yeah.
It doesn't even exist.
Yeah. And then there it is. So then it's pulled down into the IVC, and they did all of this while on ECMO.
So real quickly, for the sake of our audience, can you explain why, because I've seen people do this before, and I've seen one person get real lucky, but also a person get very unlucky. What happens if you just try to advance it and hope it goes into the inferior vena cava. Why is this necessary, and why can't you just simply advance it?
Well, especially if you're advancing it blindly, I mean, you could go right through the heart.
Yes.
And even if you get lucky and you get it roughly in the right position as far as the IVC, then you're going to also have to make sure it is actually oriented correctly as well for the return port, right?
But it's that advancement. If it's in the right atrium, if it's not in the IVC, it can
go right through
angle and go through the tricuspid valve into the RV.
Right.
You can think you're going down, and it's going to hit the IVC RA tissue and possibly perforate right through it.
And it can also curl up. We've
Yeah.
seen that before, where you're advancing, and you're even using fluoro, and you don't ever see it coming down. It's because it's curling up. We've seen that once before too.
You really need fluoro to, I think, I do not. Now, with the baby, it may be different, but with adults, I don't think you should be trying to advance any of these catheters even with a wire, using TEE only, because you only have a small window. So yeah, you see the wire in the IVC, but you don't know if the wire made a loop and went down, and you go advance that catheter, and boom, you perforate the heart, and you're done.
I know when we make minor adjustments bedside, often we're looking at where the markings were on the cannula, or I should point over here, the cannula, and maybe for minor adjustments, that's fine.
Yes, if you know it's in the IVC.
Right.
I'm only talking about situations where the cannula is no longer in the inferior vena cava. So if it is in the inferior vena cava and just needs to be advanced a little bit, that's fine. You can just do that, take an X-ray, advance it.
Right.
What you think it needs to be, take another X-ray. But for rotational things, I don't think that's really an issue either.
Yeah, that's actually,
fluoro.
I think, the easiest thing to have to do, as long as you understand where the
or if
outflow
it's too
is.
deep, coming back a little bit.
Right.
You can do all of that blind and just confirm with X-rays. But once it is no longer in the inferior vena cava, once it is in the tip is in the right
floating,
atrium,
as they say.
yes,
Yeah.
don't just try advancing that thing,
Right.
because
Well,
that
and
can be
with
devastating.
children, I mean, maybe that's because we're not in the pediatric world, but everything is so tiny.
Yes.
The smallest amount of error, and you're going to have a big problem.
I think so too.
Okay, let's get to the next image here. So, let's get that out, and there we go. Okay, so this is real-time ultrasound images of patient B, which was a 3-month-old male on VV ECMO with the snare surrounding the tip of the Avalon cannula in the right atrium, and then it's repositioned down into the IVC. Okay, so let's look at this one again with a little bit of a pointer. Okay, so this one's a lot easier for me to see. Obviously, they've got the arrows too. So we're here, and then it's snared, and then they're pulling it down here so that it is much closer and into the IVC there.
Right.
But that's a really good image, I think. Very easy to see. Okay.
And you can really appreciate in that it's not necessarily just a straight line.
No, that one is not a straight line. Do you see that sort of maneuvering they had to do there?
You see how it comes, right. If you just advance that catheter, you can easily see where it's going to want to go, possibly down into the LV, which is to the right and above.
Yes, right.
The arrow, that left arrow.
Yep. Okay, so let's talk about their 3 patients. So patient A, 2-month-old male, 4.4 kilograms with a BSA of 0.259 meters squared, acute hypoxemia and hypercarbic from staph pneumonia and human metapneumovirus, which I think most people know as HMPV, VV ECMO, 13 French Avalon placed in the right IJ, 30% recirculation with patient desaturation, and this was just a few days after they were on ECMO. Bedside ultrasound found cannula tip in the middle hepatic vein. Several unsuccessful cannula adjustment attempts by the surgical team using echo guidance. And this was, they tried a few times and then they sort of left the patient alone, and then they tried a few times over a few days, if I'm not mistaken. Then they decided to get interventional radiology involved. They took the patient down to the interventional suite. They had ultrasound and fluoroscopy utilized with the transfemoral snare technique. The cannula was successfully repositioned. No complications, and they were expecting possible femoral hematomas, bleeding, limb ischemia. The ECMO flows and the patient saturation improved. The patient had a 23-day ECMO run, no additional cannula adjustment, and was discharged home.
Well, that's good. It was a good result, good
Yeah,
outcome.
good outcome. All right, let's get into patient
Yeah,
B.
see that staff. Go back to that diagnosis.
Yep.
Yeah, see.
Well, and we're not looking.
Pneumonia.
Yeah, we're looking at a lot of these patients, especially in the pediatric world, have very recoverable
Yes.
disease process that's going on. So this patient should recover, you know? Okay, patient B. 3-month male, 3.99 kilograms with a BSA of 0.253 meters squared, premature, 27 weeks, PDA, ASD, acute respiratory distress, again from HMPV, VV ECMO, 13 French Avalon placed right IJ, 39% recirculation. Now this was on day 9, so initially, you know, it was okay.
So they must have been using the transonic elsimeter if they know it was 39% recirculation.
They do not mention that, so I'm not
How
sure.
would they know it was 39%?
It said estimated from chest X-ray, so I'm not sure really how they're doing this, but
Okay.
yeah, they don't get a lot into that. Chest X-ray, because I wanted to talk about that a little bit. I wonder, you know, what technique they're utilizing, because I know we've discussed the transonic elsimeter and how it's just become a regular part of our practice. You know,
I don't know how you could come up with a percentage without. I mean, you would have to know information that you can't get. You know, because there's just no way to do that if your pump is turning.
they really just don't get into that, because I looked very carefully to see if they you know, even hinted at that they were using some sort of device like that. Okay, anyway, 39% recirculation on day 9. Chest X-ray and echo, the cannula tip is in the right atrium with the return port jet at the RA wall. They had unsuccessful attempt to reposition cannula by the surgeon using echo. The cannula was successfully repositioned by the transfemoral snare technique bedside by interventional radiology using ultrasound only, because for some reason fluoro wasn't available at this time.
Now, I think you could do it ultrasound only as long as you're using this snare,
Yeah, maybe so.
because,
Yeah.
again, you're not going to push. You're pulling it, and it can only go the direction that the wire is coming from.
No, that's true. It's much more controlled.
much safer.
Yep. Patient saturation had an immediate improvement, no complications, 14-day ECMO run, no additional cannula adjustment, and discharged home.
So can we talk about this, or do you want to go on?
Yeah, we can talk about this.
Okay, so a lot to unpack in this slide. One is the recirculation and what that really means. When you're saying a 39% recirculation, let's just hypothetical, we'll just use 40% because the math would be a little bit easier. If you're flowing 2 liters, we'll say.
Yep.
60% of that 2 liters or 40% of that 2 liters is not effective.
Right.
So it's only going to, your effective ECMO flow is only going to be 1.2 liters, not 2 liters.
Right.
You lose 40%.
And I didn't get into all the weeds of this, but I'll tell you, since we're talking about this one a little bit more, they did a few things before they attempted to adjust the cannula. They gave volume. They placed a shoulder roll. They, let's see, they titrated flows to attempt to improve recirculation, and there was no improvement at all. And here's what they said. Without improvement in recirculation and visible on the echo, the cannula tip was present in the right atrium. So finally, they just gave up and said, we're going to have to do something about this.
I would say anytime the cannula tip is in the right atrium, you're going to have significant recirculation, and there is, in my view, nothing you can do to improve that other than repositioning the cannula. So I certainly applaud their efforts, but I could have told you up front that that wasn't going to happen.
Yep.
It can't from a physics perspective. It's impossible to improve that because of where the cannula is located, right?
Right. Even at low flows, right? Because we're used to much higher flows.
Right.
But even at low flows, you're going to have it where it's just going back through.
Yeah, it may be less, but your effective flows
is less.
The patient was doing their PO2 was, I'm sure their gases looked horrible.
Yeah.
But we've seen that ourselves. I think this is another reason though why having and I'm a big believer in that transonic ELSA meter. We talked about that. It is FDA approved, interestingly enough, for use with this. So it's been validated. The FDA actually says.
And can you believe we've only had it just a short period of time?
A little over a year.
Yeah.
Right? Year and a half, maybe.
Year and a half, I think.
Yeah, but it came in very useful.
Yes.
And it gave us a lot of good information.
It
And
did.
it's not just whether your cannula is positioned well. It can give you an early warning sign for right heart failure. It can be a validator of hyperdynamic state. We showed that on some of our simulations, which I think we need to do more of.
And we even used it on some of our exotic cannulations on monitoring the flows.
Yes, having multiple flow meters so that you don't have to move it from one to the other to see what your flows are. You can actually see.
You have
all
live,
of them
real-time flow.
Yes, absolutely. And modulate it so much easier, or adjust your clamps, or however you like to do it. Let's not get into C clamps versus tubing clamps.
Let's not get into that debate.
I almost wanted to do it. I almost wanted to do it. But for those of you out there that like C clamps, I prefer tubing clamps. I do not like using C clamps for a variety of reasons.
We need shirts, Team C clamp and Team tubing clamp.
Yeah, there's only one person I know going to get a Team C clamp. So, but then, of course, later on today, we're going to the Weston Waterway, and we're actually going to be doing an ECMO, a quasi-ECMO course for the transonic sales representative that work with the ELSA meter to help them better understand ECMO, since their device is very specifically designed for that purpose. And so we're going to be doing that later today from 1 to 4. So this is all this actually ended up fortuitous. It wasn't planned.
I know. I wondered if you planned the lineup.
No, we changed the schedule for transonic several times. Remember, we were supposed to do it last month. It's been changed multiple times. So finally today, it's actually going to happen. So that should be a very interesting, I think, session with those guys and help them better understand why it is so effective, so they can go to our colleagues that may be watching today and show it to them and really explain it to them well. Sorry.
Absolutely. And one thing to note about that device, which I think is great, anytime you're trying to get a new device into a facility, it can sometimes be hard. And this device is mobile. So we had one in the unit that we used, throughout the different ECMO runs. And so that's nice.
The unit, how about hospitals?
Well, I know, but
we moved it hospital to hospital.
Ideally, you would have one at each facility. But this isn't something you have to have in every room, as you're trying to implement these changes and get these new devices in.
Okay, so to my colleagues out there, learn from my mistake.
What's that?
I used my device. The hospital never had to pay for anything.
Yeah.
We ran it from hospital to hospital, and the hospitals were actually upset and offended when it wasn't in their facility, even though they never paid for anything. And now I'm trying to get the hospitals to buy it, but because the pandemic seems to be abating. Yes, in remission, nobody wants to buy it, and it's like, look, I mean, if this happens at you, I'm not going to keep running hospital to hospital bringing this device. So to my colleagues out there, if you get it as a trial run, like what do we call that? Evaluation. Don't
device.
let them keep it too long, and don't whatever you do, don't offer them anything for free. You get to look at it, but if you want to use it on patients, you got to buy it, because I'm going to tell you right now, it's a nightmare.
Well, there were plenty of shifts that your ending shift at ECMO was, and please clean the transonic and drive it to the next location.
Yes, yeah, exactly.
Okay, let's talk about the last patient here. So patient C, 13-month-old male, 10.8 kilograms, BSA 0.465 meters squared, acute hypoxemia, hypercarbic, respiratory failure, and they had RSV, septic shock. So the ICU made the decision to do VVA ECMO because they were thinking after we get past the shock, then we'll be able to easily transition to VV. Makes sense. So 19 French Avalon was placed in the right IJ, a single lumen cannula in the right common carotid.
That is so incredibly frightening to me.
To go in the carotid. It's pretty common in the pediatric world.
I know.
Yeah.
It's just
the femorals are just, they're really small for cannulas. It's very, very difficult.
Yeah.
So I guess they're just really tiny. The plan was to transition to VV ECMO after a few days.
You don't have to worry about Harlequin.
No, you don't. Tip of the cannula dislodged into the hepatic vein after placement. So this is immediately. After they cannulated, they were moving the patient from the surgical bed to the crib, and the cannula dislodged.
So it went into the hepatic, so it went too deep.
Yep.
The tip of cannula dislodged into the hepatic vein, so it must have gone off to the side.
Very small spaces in there, Multiple unsuccessful attempts by surgeons to reposition the cannula. The cannula continued to migrate up over the next 2 days. Return to the port, or the return port was at the SVC. Patient progressively more hypoxemic, and the cannula successfully was repositioned with the transfemoral snare technique bedside using fluoro and ultrasound. ECMO flows and patient saturation improved. No complications, including no thrombotic events, because of course, we're also arterial flow there. Converted to VV on day 5. 21-day ECMO run, slowly progressing to discharge at the time of this paper was being written.
So very interesting. So it must not have been too deep. So if the return port, which is the middle section
I
of
think
the cannula, was in the
first dislodged and then it migrated because they left it
up. Okay.
Yeah, that's how I read it.
Okay.
And interestingly enough, I didn't put this on here because honestly I ran out of room on this slide, but I wanted to read you something about this. So let's just get into the summary of this patient C. The patient experienced no complications related to the repositioning procedure. The patient also did not experience thrombotic or other complications related to the use of both lumens of the Avalon cannula used as drainage limbs.
Say that one more time.
Okay. I think you just want this phrase. No complications related to the use of both lumens of the Avalon cannula used as drainage limbs. So they're draining out of both sides of the Avalon cannula is what I read. Yeah.
You could do that.
However,
as long as you're VA.
Yeah. However, we are not recommending this technique.
Yeah, I can see that.
I've never seen that or I guess I've never had a reason to see that where you're using both sides of the Avalon as drainage.
Yeah, I've done it before.
Oh, have you?
Yeah.
Huh. What was the reasoning? Why did you decide to do it that way?
Increased flow.
Yeah.
So we went VA.
Yeah.
We converted to VA. And instead of trying to change everything out, I just used both of those limbs and came back as my access. So basically, I had just a big, giant right atrial, drainage.
Yeah,
and went back to the femoral artery.
Because when I did it, remember that exotic cannulation that I did?
You can also use it both for return.
Yes.
You can do that too.
Yeah.
You can add another femoral venous cannula for access and run both returns in that way if you want to.
What I did was used the traditional side for drainage on the Avalon, and then we put in a femoral, wide it in, so then we had a femoral vein drainage. Then we had going into the left femoral artery for return, and then we looped off the other one.
And the Avalon. So you had the Avalon coming. No. You had both Avalons out to a femoral venous. No.
One side Avalon out. The other side was flushed and put on a loop and just filled with crystalloid because we knew we'd convert back. But yeah, because we were kind of thinking on the fly. This wasn't planned. We were bedside and we're like, what can we do? And I didn't even think of doing it that way.
Yeah, you could do that.
That's interesting.
It's very easy. It really works well.
Yeah.
Let me tell you something. You get a lot of flow.
You get a lot of flow.
You have no restriction to flow on your access side. Your access, if you were to be measured, we don't measure pressures.
Yeah.
But if you were to be measuring the pressure, it was not very negative. We had CRRT hooked up, so I could tell what that pressure actually was.
Right, because you're reading it through the CRT.
And it was very low.
Yeah.
So not very negative.
Not very negative. Right.
Right.
I got it. Okay, so the author's conclusion, we describe a safe technique for repositioning of dual lumen cannula in pediatric patients without cessation. What? What's my problem with that word?
Cessation, yeah, you got it right.
Of ECMO support using a transfemoral snare lasso guided by ultrasound and fluoroscopy. And we're ready to discuss, although we've been kind of doing that as we go here.
No, I think that's great. I really, actually, I mean, I know you felt that this was a challenging paper because it was the pediatric world, but I just think so much of it. Of course, there may be pediatric people out there that see this.
Oh,
and
absolutely.
who are going to say, hey, this, because we really don't spend a lot of time.
That
in the
was
PD
my
space.
point, is just I was a little bit intimidated because I don't read anything on pediatrics anymore. I used to have a real interest in it in the beginning because I kind of thought maybe one day, but then that one day never came. And so I feel very ill-equipped to discuss things in the pediatric world. Even just looking at those tiny little weights and BSAs, it's hard to really comprehend for me.
Well, I feel the same way.
Yeah,
so,
they're just tiny little things.
Yeah, I can't do that. I just can't do it.
Yeah, so I did think this was actually a really interesting article. It's not something I never thought of. I guess IR people think about these kinds of things, maybe not specifically in ECMO, but it's a great application.
Well, I think if you're going to do ECMO at all, you need to know this technique because if you are going to do VV ECMO with a single cannula technique, dual lumen, single cannula, dual lumen, you will be confronted with this problem.
Well, and this isn't a new problem because I didn't get a chance to really read all of their reference articles, but I looked at, briefly, just looked at a couple of them, and even as far as 2017, in the Journal of Artificial Organs, there was an article that was published about bedside repositioning of a dislocated Avalon cannula. So this is not a new problem by any means. And then all the way up to this 2020, the same year that this article was published, there was a reposition of the dual lumen ECMO cannula using this transfemoral lasso. So this group was not the first to do it, but they were the first to, I think, do multiple patients and then put them together in this particular way, describing how they did it. So,
yeah, it's really interesting because, again, this is not something that that is that uncommon to us in the world we're in. And as you continue to, which brings up yet another issue, and I'll tell you what it is. But I think as we advance in how we deliver ECMO, and especially those places that ambulate, and they or you're proning, and you're not using a prone bed, but even with a prone bed, it's treacherous. But without a prone bed, and you're just flipping the patient, and they're big patients, your risk of catheter dislodgement is very, very high.
Well,
And-
even just having these long runs and really having to take care of these patients, cleaning them, changing their
Yes.
beds, repositioning them to make sure that, you know, they're getting the pressure off the different parts of their
Yes.
body.
Sitting them up.
Yeah,
Getting
all
them
of
in
those
the
things.
chair.
Yeah, not even talking about something as
Turning them.
crazy as proning, but just turning.
Yes.
You know, you can, or especially if they're awake, just trying to give their neck somewhat of a break, getting them to be able to move it around a bit. You're
Mm-hmm.
at a high risk for really dislodging that cannula.
Yes, which brings up how it is secured.
Mm-hmm.
We have had as a group one episode
Mm-hmm.
of catheter of decannulating unintentionally with the access, the superior vena cava coming out. Now, it did get fixed. It did get replaced. The patient did get back on ECMO. The patient did not have an untoward event from that episode, but it was quite dramatic. And those are realities of doing this, is
Well,
you have
and
to secure that
Absolutely.
cannula.
Well, and it's even beyond that. I think that cannula was secured, but this was an awake patient that was very agitated, and I think that's another safety.
And yanked on it, yeah.
Yeah, another safety, you know, area that we really
That
have
can
to.
happen, right, that can happen that way. Well, you know, but I have to say, you know, look, I mean, I one of the things that I think, and there's several things that, I mean, all of our docs are incredibly talented.
Sure,
There's no doubt
absolutely.
about that. But one of the things that I think Dr. Matoyer does really, really well is that cannula might migrate more distally, might advance a little
Yeah.
too deep.
It's not coming
over
out.
time. It ain't never coming out.
No.
And he puts a big proline in the skin at the cannula insertion site, ties that, and then loops it at the Y where the access and return are, and comes back around again, back through the skin, and then ties that down. You're going to have to pull awfully hard. I mean, the patient's not going to take it out themselves. I don't care how hard they pull, because they're going to take their head with them, and it's not coming out.
And it's not going to feel good.
No, it's not going to feel good. It's one of the many things that I think he does very, very well, is he really secures it. Not everyone feels the same way, and not everyone secures it to that degree.
Different techniques,
but
right?
I think that may be something we could do to improve. It reduces our stress level.
Right.
We can deal with a cannula that goes in a little too deep. It's really hard to deal with a cannula that comes out.
Well, that's
So-
a emergent situation. You're having to deal with that right away.
Even if it's not all the way out of the patient, just
Right.
high recirculation
Right.
creates its own set of problems, right? If it comes
Absolutely.
into the right atrium, you've got a problem.
I've had a decannulation once
Did you?
in the pediatric world in my very early career. The doctor was rounding and had someone there that they were training and was showing them. You know, we were on VA ECMO, and arterial cannula pulled out, caught it on something. You know, they're just tiny little things, and it just
Oh,
came right out. Now, believe it or not, he got it back in just like that. But that's because he was the surgeon, and
don't
he
know.
did it. That patient ultimately didn't survive, but it was not from that event.
not because of that event.
Not
yeah.
because of that event.
Man, I'll tell you what.
that was
it's a-
something. I
that's-
think I was only out maybe 2 or 3 months.
How big were your eyes?
It was that was a crazy run. I also had we use roller pumps at
Yeah.
pediatrics.
Yeah.
And I had, the way you didn't change your circuit until you absolutely had to is you walked your tubing and
Right.
your roller pumps.
Because of spallation and tubing fatigue.
And I had a same patient, my shift still, but different day. I had the tubing split.
Ooh.
Crazy.
Wow.
We actually did drills in Texas Heart for that, but you don't think you're ever going to actually do it.
You have to change that whole boot.
Yep,
Yeah, you got to change that whole boot. You got to, and it's going to be a bloody mess.
it was.
Yes, generally it is. But interestingly, I wanted to talk about that case that you did. We were doing it together. It was I think it was your first hyperkalemia case. And we were so it was minimally invasive, right? You have the patient position with the right side up because it's going to be a right anterior thoracotomy, cannulated femoral vein, femoral artery. And we were giving the potassium. And the one thing about the hyperkalemia technique is you have to be somewhat careful about giving the potassium too fast, because if you give it a little too fast, you get some transient hypertension, and each patient's going to be a little different, but it can be pretty significant. Now it's short term, but it's still pretty significant. And we were giving the potassium, maybe gave it a little too fast, pressure went up, and for whatever reason, you just were watching it. I don't know how it happened. It was fortuitous. You had a clamp in your hand, you're looking, and you literally watched the arterial cannula back out and come out, and you clamped it like it's like you were. It's like you knew it was going to happen. And that was Dr. Matoyer, and he got the cannula back in right away. He was able to put it back in. It was mostly drama-free.
It was a high-stress moment.
But it was a high-stress moment, and got the patient back on bypass, and everything was okay. But it was from that event that he started more robustly securing all of his return cannulas, the femoral, and then that translated to, I'm going somewhere with this, with how he ties down the Avalon, because that's exactly what he does with the femoral arterial now, if you ever noticed, is he goes around with a big proline, and then where the lower lock is, he makes sure that's on good and tight, and he puts the proline around it so that there is always constant inward pressure of the femoral arterial cannula.
It's lassoed and it's pulling it.
Right, always right. It cannot come this way. It is not going out.
He's a smart guy. He also probably got tired of our almost daily calls that one of the beds needed the cannula adjusted.
He did get tired of that. And I have to tell you, one of the funniest things that he ever said, I was in the unit, and I show this video a lot, and it's of the Avalon, and you see the line going into the patient red and then coming out, and you see it pulsing red, pulsing red, pulsing red. And, of course, I'm trying to point that out to him.
Maybe that's
we had like
how they determined their recirculation. They have eyeballs that can read.
No, I don't think so. And so I don't believe so. And we had been, I don't know. I had been up for I don't know how many hours, and he'd been up I don't know how many hours, and we had 6 patients in this unit that were on ECMO at a hospital where we generally would only see 1 ECMO,
maybe 2 for just to overlap, just
a short period of time, and we have 6 going at this one moment, and one of them going back and forth to the operating room because he keeps blowing out his lungs, and chest tubes going in and bleeding going in, and oh my God, we had mass transfusion protocol going on 2 different patients at the same time. And man, I'll tell you what, that was some crazy times. But he stood at the doorway, and he was yelling at people, but I ended up being the center point. I ended up being the martyr for the entire unit. And he stood at the doorway and he said, "Damn it, Joe, my brain works faster than every computer in this blanking hospital." And he stormed off. And you got to remember, he's like 6'5". He's got long blonde hair. He looks like a surfer dude from California. Wears these big cowboy boots.
He's a pretty smart guy.
And but he's from Center, Texas. He's from Nowheresville, USA. And the guy is incredibly talented. There's no question about it. He is smart.
You were challenging him that day, though.
Man, I'll tell you what. Well, apparently I challenged him right into meltdown. But he does think very highly of his brain function because he clearly thought his brain worked faster than every computer in the hospital. I don't even know what it had to do with it. I just need you to adjust the damn cannula.
No, you were. I remember this, and so I'm going to come to his defense here a little bit. You were telling him too much. You know, everybody was coming at him with information. He was just trying to process something, and you know, he needed a moment to just kind of think.
How come you never defend me, Tammy?
I do. You're just not around for it.
I'm just not around for it. Okay.
Okay. We need to spin the wheel.
So, yes. So I'm gonna. So, Abdul Rahman Al Humiani. We are spinning the wheel for you, and God knows I hope you don't get an aortic dissection case or you don't get extra call. You get something good. So, Abdul Rahman, I hope you're paying attention. Tammy is going to spin the wheel for you. Here we go. Let's see what we're going to get.
Yay!
He gets a cup. Man, it was close to an aortic dissection.
I would have spun again.
Where's our cup? Oh, I don't have our cups.
No, it's okay.
Yeah, but we have our cups.
Yep.
We're going to send them to you. We'll send you 2 cups so that you can share your favorite beverage with your loved one or your partner or one of your colleagues at work, whatever the case may be. But we need you to email us your physical mailing address in Saudi so we can send it to you. We'll send it via FedEx or UPS or one of those organizations, and you should get it in hopefully some reasonable amount of time before we're all, hopefully it'll get there. Supply chain and transport times.
Things are getting there. Just taking a while.
We're going to get it to you. We will get it to you.
You want to talk a little bit about what we're doing tomorrow?
Yeah, let's talk about what's going on tomorrow. You know what's going on tomorrow?
Yes, tomorrow is an afternoon program. I believe it's at 3 o'clock. It'll be PerfWeb 77 Day 2, and it will be with John Ingram's Knowledge Nuggets. And aren't we discussing oxygen-free radicals?
We are.
Well, John is discussing.
Understanding oxygen-free radicals. Yes,
yeah.
Yes, ma'am.
And you will definitely get some nuggets to be able to take home with you.
Absolutely. Well, I think John's programs are really good. They're excellent programs.
They're
he does
excellent.
a fantastic job. You know, he's working on getting his PhD.
Oh, wow.
And is his PhD? Yeah, his PhD, right? Or his master's.
I'm not
Maybe
sure.
Maybe it's his master's. I'm not sure. No, he's working on his master's. That's what he's working on.
Got it.
And so he's doing a lot of research and really doing he does, but I think his programs are very, very informative.
Absolutely.
The guy is extremely smart. And always reliable. He always answers his emails. Of course, he does his show. You've got the Tammy Sparacino Journal Club. I've got the John has the Knowledge Nuggets. I have PerfWeb. We have the Vanderbilt Faculty Forum, and a lot of stuff going on. We're going to try to add to that.
We're going to add some additional programs this year.
We have some new technology to help when we do remote programs that we don't have to use Skype or Zoom or anything like that. It's our own internal software.
We have new cameras, so hopefully you can tell the difference, right?
Difference, yeah. Hopefully everything looks good. We've got some new backgrounds and stuff. We're trying to put together a program that continues to grow and continues to be good. Let's see, we have some additional questions. Amit. Hey, Amit, how you doing, man? When you put a patient on an Avalon, adult patient, do you keep your lines very long so they extend all the way to the patient's feet? So, quick answer from me is no. I hate doing that. Anytime you have significant, in my opinion, and this is my opinion, you have excessive redundant tubing, you have a higher risk of problems occurring, not to mention you're occupying more of the patient's blood volume. The caveat to that is if you're going to be ambulating the patient, getting them into a chair, etc., right, you have to have enough length in order to be able to do that safely. So it is a balance of having enough length to do what you need to do safely and not so much length that you have to wrap your tubing around or coil it or going all different directions where, in my view, that increases your risk ratio to a point that I don't like it. So that's my opinion. Tammy?
I agree with you. I would say normally our tubing comes down to just standard in our pack, comes down to where we're positioning the ECMO machine around the patient's in between sort of their knee area and their hip area, and our tubing is about that long with just a little bit slack hanging off. Now, as these runs go longer and we do some change outs, we typically, for the most part, I know you like to do it at the cannula, but most of us do it.
I've stopped doing that.
Okay. Well, a short distance from the cannula, we'll go ahead and leave just a tiny bit of tubing there. And so you do get a little additional extra length, which can be helpful. You just need to make sure that if you're doing multiple change-outs on these really long runs that you're not continually adding to that, keeping it about the same length for ambulating and for when you go to CT. Often CT is a big challenge because, you know, that the bed is sliding in and you're, you know, machines.
That is a challenge.
Yeah,
yes.
Sometimes you have just enough.
But I think, well, and that's a different issue. So whenever, in my again, my opinion, and just to sort of go backwards, if we may, I used to believe that you should change the ECMO at the cannula connection site. So wherever the circuit tubing attached to the actual cannula connectors, but I have since abandoned that because I think that there is just too much risk of having a cannula positioning problem. So I try to avoid that now.
Well, and occasionally.
But I don't like to increase the length of the lines every time that I do have to change an ECMO circuit. I try to tailor the line so I'm about the same
Exactly,
length.
about the same length. That's what I was saying. Because again, if they're too long, even when you're ambulating, that's a risk for tripping over the lines,
Yes.
running over the lines. So I think it's just a little bit of using your, you know, common sense judgment that you want a little bit of slack, but not too much. And when we were ambulating our patients, we were in the leading position initially when they're sitting back in the chair, but then once they're fully walking, we were in the caboose position, if you will. We were the last, so we're coming up over the shoulder and right behind them.
Yes, correct. And then they would have a chair. We would actually be behind the chair.
Yes.
So that if they needed to sit down immediately, there was somebody right there.
Right.
And that seemed to work out pretty well for us. Amit had a second follow-up question. Do you secure the lines around the patient's head? Yes.
Yes.
And is there a special device that you use? So yes, but no.
It's not made for that.
Right. So we use a headband that's got Velcro. And now I will tell you, there's some things that you have to.
It's what's it? It's for securing.
The trach collar.
No.
No?
No, that's initially what I thought we were using it for, but that's not what it's for. It's a leg. It is something that goes.
It's a leg band. That's right.
It's a leg band.
Is it for the?
It's not for the Foley. I feel like it's for maybe like dialysis catheter or something, but it is because initially we tried
the white headband.
Yes.
It's got black Velcro.
It does, but it's the right size. It's comfortable on the patients because it's soft. It's made of a soft material because most of these patients, you know, that we had lately were awake. You know, when they were asleep, we were still doing it, but you weren't worried so much about them, you know, thinking it's itchy or anything. But it works quite well.
It does. Now, with that said, there's two things you have to be very aware of. It will slide off.
Yes.
And that can make everything go cattywampus, so you have to be careful about having it there. The second thing, which is very important, is that cannula will rest right on their ear, and I have seen several ear wounds, pressure wounds, and abrasion wounds.
You need to make sure you have the
padding.
The padding, right?
Yeah.
Initially, you can
We
start
use
off with
4x4s.
4x4s, but then we transition once the patients are awake to using those little I forget what they're called, the little flower ones.
Yeah, that's it's for the pressure wounds that go on the back. I can't remember the name of them either.
But it's a pressure wound, sort of tegaderm, and we would put those on the ear, and that helped a lot.
Yes.
A lot. Then something else you need to keep in mind, securing it to the head is really just for kind of guiding the cannula and the lines to be in the right direction. There's a lot of weight when they're up. Now, if you're just ambulating them to the chair and then they're sitting there, then you can secure the lines sort of backwards, to the chair. But if they're walking, you really need to be thinking about that weight is going to be pulling down. It's not comfortable for them, one, and two, it can kink off the cannula or torque it some. So you need to make sure that you have a technique where you are really providing the holding the weight of the lines.
Yes. You're holding it up and not you're distributing the weight more towards holding it up versus allowing the cannula's weight to just pull.
Exactly.
Because it will flop
And that can be
over.
challenging with the taller patients. I know we had one very tall patient that we were ambulating, and he did quite well, discharged home, all of that. But when we were ambulating him, and it was a slow process, he was very tall. I'm holding the lines up here. He was a tall person. So your physical therapist that's there working with you can help with some of that too, right?
Absolutely.
They're very creative in coming up with ways to really help these patients feel secure, and they were actually pretty quick.
We were using ACE wrap.
Yeah.
We used an ACE
wrap.
bandage around his head.
But the physical therapist came up with that.
Yes.
Yep.
Yes.
Exactly.
Yeah.
Well,
So what do you think about since we Abdul Rahman is won something? Since Amit had two good questions, do you think we should spin the wheel?
Yeah,
for
let's
him
spin
too?
one more
So,
time.
Amit, make sure you send us I probably have it already, but send us your physical email address unless
physical address.
Yeah, physical mailing address.
Yes.
Yeah, that's what I meant.
Okay, let's
Thank you.
bring the
Great
wheel
show,
up
by
one
the
more
way, he
time.
says.
Oh, thank you.
Complimented you.
Thank you.
So don't give him a bad prize.
I never give bad prizes.
do.
It's you. I spin again. Nobody gets an aortic dissection here. I don't even know why it's there. Nope.
Oh, Amit, you get an aortic dissection.
We're spinning again.
Oh, God, I hope you're not on call. Oh, my God.
Who made this wheel?
It's not spinning.
It's a
There it
mean
goes.
wheel. It's a mean
Hold
wheel.
on, wait. You got to remember because it's delayed online.
Yeah.
So
Oh, it's a cup day.
he gets cups too. Okay,
All right.
so both you and Abdul Rahman get cups. Oh no, he said. Hope you're not on call tonight because it was Tammy. It wasn't me.
Well,
I didn't spin the wheel.
it's
She
not
did.
real.
But
It's not
you're going to get a cup instead. That way you can have coffee during your aortic dissection. All right. We'll see you all tomorrow. The afternoon program, you
3 p.m.
said, is 3 p.m.
I believe it's
John
3 p.m.
Ingram's Knowledge Nuggets. And we'll look forward to seeing everyone then. Thank you all so much for being a part of our program. And send us your emails. Send us your suggestions. Become a faculty member. We'd love to have you. You could have your own show.
You could do it remotely.
You can do it remotely. You don't actually have to be here, but you can come here too because this is a great studio, a lot of fun, great technology, but we have the technology to do it from anywhere, and that's the important thing. So we'll see you all.
Thanks.
Bye,
Bye-bye.
Tammy. Thank you. Good program. Good show.
Thank you.